My talk today is long-term outcomes of prostate brachytherapy. There's a lot of stuff out there. The objectives of this talk will be to review some, and it's mostly Mount Sinai data, some of our long-term data, because we've been fortunate, Neil and I, to work together for over 20 years to have a very robust data base. And I feel fortunate that although brachytherapy incidence is going down, my incidence has actually been going up over the last 3 years. So we've been keeping this data, we're looking at it, and we're kind of seeing some very interesting things and able to look at and write about some things from the long-term perspective. I'll talk a little bit about some PSA control rates, what we see in failures. Obviously, I'll touch on in some of these studies what we're seeing in terms of distant metastatic disease. Obviously, overall survival is important, and some of the things that affect overall survival. There's been a lot of things going on in our literature and prospective trials on intermediate risk patients and how we treat them with brachytherapy, so I will touch on that and kind of to address how are we treating high-risk patients and what do we know about that, and obviously within this try to highlight some of the randomized trials that have been done recently in the area of prostate brachytherapy. So this is a abstract that we presented at ASTRO. We're in the process of writing it up, and it's not really a new phenomena, but I thought it's been holding up for so long, and I think in certain ways we've forgotten about PSA doubling time or the importance of PSA doubling time. But basically what we did is we looked at a population of patients that we treated between 1990 and 2015, 2771 patients with localized prostate cancer. They all got brachytherapy as part of their treatment, and what we looked at is looking at the overall outcomes and factoring in all the factors that we typically do, like PSA, Gleason score, stage, etc. But in addition, we wanted to see the doubling time. We kind of wanted to revisit that, the PSA doubling time. What happens to patients as their PSA goes up, and is that a surrogate for something? And this was the outcome of this, and again, we're in the process of submitting this. And again, this is held up over time, and it's really quite interesting. At least I find it. So we broke up patients into less than 6-month doubling time, between 6 and 12-month doubling time. Those patients, obviously, that didn't fail had no PSA failure, and then patients who had very long PSA doubling times. And what we found was that there were a very small number of patients, and what's interesting, they usually were high-grade patients who developed clinical metastatic disease without having a rise in PSA. Very, very few. The vast majority have PSA failure and were able to be given a doubling time. And what we found was that if your PSA doubling time was greater than 12 months, really out to 20 years, none of these patients developed metastatic disease. And again, all these patients were treated in different ways. Some were not treated, some were given hormone therapy, intermittent hormone therapy, many different things over time. But if your doubling time was greater than 12 months, you really didn't develop metastatic disease, at least in our study period. And if you obviously didn't have a PSA failure, most patients did not, well then a couple of those high-grade cancers did, but not a high percentage. But then when your doubling time became shorter, between 6 and 12 months, that's that yellow line, you can see that's where you got a statistically significant increase in develop a metastatic disease. So we're talking about 30% of those patients developing metastatic disease within 15 years. And then if your doubling time is less than 6 months, there was a really marked effect again, and those patients, 60% of those patients developed metastatic disease by 15 years out after initial treatment. Same type of effect, a little bit less pronounced on overall survival because now you're getting competing causes of death, but really no significant difference between the long doubling time greater than 12 months and patients that did not have a PSA failure, but a significant difference once your PSA failure was between 6 and 12 months, where the cancer itself is contributing to the overall survival rate. And of course, the worst group is, again, PSA doubling times less than 6 months. So I think the take-home message of this is that with all the new novel therapies that are being developed for metastatic disease or castrate-sensitive disease, perhaps some of those should be use in patients who have very short doubling times but have yet to manifest metastatic disease. That's an interesting thing which we should have out in press pretty soon. And now I want to switch gears a little bit because I said I would be talking about intermediate risk patients. So intermediate patients are pretty much characterized as those with Gleason 7 or between PSA between 10 and 20, and obviously people have different definitions of the T stage that make it into that group, but for a long time, since I've been doing brachytherapy, I know Juanita, we have talked about and debated how these patients should be treated. So for a while, they were treated with an implant alone. I know Neil and I, when we first started, our only criteria for adding external beam was to have a positive seminal vesicle biopsy. Every other patient got treated with an implant plus or minus hormones without external beam. That changed probably in about 1995. I know the Seattle group, which again started out doing a lot of implants, also were doing a lot of monotherapy, but then started adding. And so this was the big debate. In other words, which are the patients that should be treated with an implant alone, or do they need the combination of external beam? And so this was an ArtcoJ trial. Brad Prestige was the PI on this trial, and it was a phase 3 trial comparing combine external beam and brachytherapy with brachytherapy alone for intermediate risk prostate cancer. And this has been presented in abstract form at ASTRO. The eligibility criteria, again, was either, and this is an important part, was either Gleason score 2 to 6 or low-grade cancer with a PSA between 10 and 20, or Gleason 7, but the PSA had to be under 10. So essentially it was one intermediate risk feature, not two. They did not receive androgen deprivation therapy. They had to have an IPSS less than 10, and then they were node-negative patients. And the treatment arms were 45 gray, standard fractionation, plus either 100 gray of palladium 103 or 110 gray of iodine 125 brachytherapy. And the brachytherapy alone arm, the prescription dose was 125 for palladium and 145 for iodine 125. And this is just the results from the abstract presentation. And you can see here, kind of looking at the first failure rates, they divided up into biochemical failure, local progression, or local progression and distant metastases. And in addition, death was considered an endpoint for failure. And you can just see the numbers of patients for first failure, 34 in the combined arm and 32 in brachytherapy. And then if you just shift over to the freedom from progression arm, which is really what we have to go by, what you can see is that in patients, so again, take-home message, in patients that have one intermediate risk feature, there was no significant difference between the brachytherapy alone and the brachytherapy and external beam. So I think that's a significant finding after all these years, and a very interesting finding. So that led me to say, okay, we had published on similar stuff like this in our database, but I said let's revisit our whole database and kind of look at that, but let's look at anyone with intermediate risk feature, and it means people that could have more than one intermediate risk. So that study was really focused on patients with only one intermediate risk, and I wanted to see if there was anything that we found differently. So this is a paper that came out this year, worked with one of the Mount Sinai medical students in putting this together, called Outcomes and Toxicity. So in addition to looking at the PSA recurrence rate, we also wanted to look at toxicity, because that really wasn't initially addressed in that abstract. And I think that's an important issue, because obviously there's the cost of adding combined external beam to an implant, but there's also the potential of adding toxicity as well. So this just kind of gives you the breakdown of the patients. All patients, we had 902 patients in this study. Brachytherapy alone was 390 patients. Brachytherapy and external beam was 512 patients. And you can just take a look at, if you drop down to the bottom of that, you will see a number of the characteristics of the patients. And they were relatively even matched in terms of the clinical stage. But when you got to the number of risk factors, it really wasn't that evenly matched. So in terms of patients that had one intermediate risk features, that was 37% overall, but 74% in the brachy arm, versus only 45% in the combined arm. And if you had 2 to 3 intermediate risk features, then that was 25% in the brachy arm and 54%. So right off the bat, we are not a randomized trial, and there was a disproportion of patients with more risk features in the combined arm, so worse players. How about the Gleason score? The same thing. If you looked at Gleason 6, it was 73% in the brachy alone arm versus 20% in the combined arm, and if you looked at Gleason 7 patients, it was 26% versus 80%. So the combined arm had a higher percentage of high-grade versus the brachytherapy alone arm. And the same thing you could see in the PSA values, where the PSA between 0 and 4, there was a greater percentage in the brachytherapy alone arm versus in the combined arm. So this is not randomized. The worst players were treated with combination therapy, because that's how we made that decision. But this is what we found in this study. So if you kind of look at just kind of what they found in the ArtcoJ study, patients with one intermediate risk feature, we found a very similar outcome. There was no significant difference between combined external beam and brachytherapy alone. The curve looks very, very similar, except we have much longer follow-up compared to the ArtcoJ. Now, when you look at patients that had more than one intermediate risk features, you do see the curve separating out, and you do see some improvement, although it was not statistically significant at this point at 0.09. But I do take that, and I did learn from that, and I still do offer combined treatment for those patients that have more than one risk factors, but I do take one case at a time. But again, showing, if you look there, that there is that difference in the separation out of the curves. But more interestingly was what was the difference in toxicity. And one of the things we looked at, because we do have people fill out the IPSS, the patients at every visit, we just kind of looked at the incidence of having either a positive at any time in their follow-up period, dysuria, urgent incontinence. These are just things that we ask patients, hematuria, stress incontinence, etc., rectal bleeding. And what you can see was that if you look at the p-values right over here, the differences were really mostly in these, urgent incontinence, dysuria, and hematuria, where you had higher incidence of these factors in the combined treatment arm. They were statistically significant. Again, this just means that at one time in their follow-up period, they had mentioned this. Doesn't mean long-term they had it. But I think the most interesting thing for me, for the take-home message, and that's why I put it in, was looking at the time to impotency in those patients on treatment. And again, hormone therapy could be given in either of the arms. So it's not a pure study like the ArtcoJ, but we did find that adding combination therapy, external beam, did significantly decrease potency preservation compared to an implant alone. So I think my take home from the ArtcoJ, from our own study and our own analysis, which is important, is I'm treating many more of the intermediate risk patients with implant alone and less patients with combination treatment. Switch gears to another paper that came out around the same time a couple of months ago. So what we wanted to do, again, working with one of our students and Dr. Stone, what we did is I wanted to look at, and I told my resident, is that how do patients do when they're 10 years out? So what does that mean to be 10 years out? Because it's really important how you define this. I said, look at the patients that are alive and that we are following 10 years or more. It doesn't mean that they are free of a PSA recurrence. It doesn't mean that they're free of distant metastatic disease, but they have lived 10 years. So what does this exclude? It obviously excludes patients that haven't been followed for 10 years. It also excludes patients that developed metastatic disease and died before 10 years. So that's important to keep. I just wanted to know how patients were doing in terms of their cancer control rates if they are 10 years out. Because again, one of the unique things about our database is we have been doing it for a long time, and we've had pretty good follow-up. So we really identified 757 men that we have follow-up on. They underwent radiation with brachytherapy as part of the treatment from 1990 to 2006, and were followed for at least 10 years after their treatment. We looked at biochemical failure, distant mets, prostate cancer specific survival, and overall survival. These were the endpoints that we looked at. And this is kind of what we found. So this is just a graph showing survival rates by the NCCN risk group stratification. The median follow-up in this group of patients was 12.5 years, and the follow-up ranged from 10 to almost 22 years of follow-up. So as you can see, we have low risk, intermediate, and high, and we looked at the biochemical, and we looked 13, 15, and 17, admitting that we don't have a lot of patients followed for 17 years. But you can see we have, of these patients that are out, again, eliminating those that die early of metastatic disease, 94% of patients, low risk, are at 13 years of free of recurrence, 87 for intermediate risk, and 75 for high-risk patients. So I think that just as this is a durable treatment, and it does work over long periods of time. In terms of distant metastatic-free disease, very low, so 99%, 13 years for low risk, 97 for intermediate, and 96 for high risk. Again, keeping in mind that is excluding high-risk patients that have died or lost the follow-up prior to 10 years. And the overall survival, again, these are patients that have at least survived 10 years, so they're the healthier patients, the younger patients, but really excellent overall survival and overall prostate cancer specific survival in all of the risk groups. And this is just some of the figures kind of demonstrating what I just mentioned. So this is biochemical failure-free survival. When you kind of select out this type of patient, you see there's no real difference between, we lumped them together because there wasn't really much difference between intermediate and high risk once they had made it 10 years. But low-risk patients did have improvement in biochemical-free survival. It was not statistically significant when you got to prostate cancer-specific survival. All the patients relatively did the same, as well as distant metastatic-free survival and overall survival. And again, the reason is because the patients dying of aggressive cancer are being removed from this cohort. We're just looking at patients surviving 10 years or later. And finally, in terms of the cyanide data, I wanted to pull up a paper that Neil first authored that came out in 2014, because I think it's very intriguing to me, and I keep looking at it and wondering what's behind it and what it's true, but it's really thought-provoking, and that's 15-year cost-specific survival and all-cause survival following brachytherapy for prostate cancer, the negative impact of long-term hormone therapy. So just to kind of give you a background, when we first started, it was the heyday of ArtcoJ 8610 and the positive impact, one of the first trials showing a positive impact of hormone therapy. We really did start using it in our intermediate risk patients 6 months, and in 1994 we gave our high-risk patients 9 years, as the other ArtcoJ trials and the EORTC came out showing the benefits with external beam only of 2-3 years of hormone therapy. We selectively started to put some of our higher-risk patients on that. So there's a selection bias in our database. There's no question about that we were putting our highest-risk patients with the worst cancer on the longest term of hormone therapy. This is just an overall survival, a cumulative survival, 10 and 15 years of our patients, and you can see that graph. But more importantly, if we go to the next graph from the paper, and this is the part that really is interesting, when you separate out patients into having less than 6 months of hormone therapy versus greater than 6 months, and again, we have done multivariate analysis, I will show you, but still, patients getting the longer-term hormone therapy had significantly lower overall all-cause survival from our study. And when we did the Cox regression analysis, the most important thing, obviously, in surviving is the age in which you enter. So that's p-value of 0.001. But hormone therapy, as well as smoking with similar p-value and diabetes, reduce your likelihood of being alive. Now, is there underlying factors in patients that got hormone therapy that could not be teased out in multivariate analysis that caused a decrease in survival? I would say yes, because they were the worst prostate cancer patients, but it does show, and other people obviously over many years have looked at the deleterious effects of long-term hormone therapy on many factors we heard about yesterday, but very thought-provoking study. I want to touch base. This kind of addresses what was discussed, which is how do we treat our higher risk patients. This is a study that came out in JAMA 1 month ago, and it's a study from 12 institutions collecting patients that have Gleason scores of 9 to 10 and comparing how they do. They broke patients up into 3 main groups. The 3 main groups were external beam alone, plus or minus hormone therapy, obviously different lengths of hormone therapy. There was another group, radical prostatectomy patients, and there was a third group of patients that got external beam and brachytherapy, plus or minus hormone therapy. And just if you look at the results in the first line here, you can see we had 1,809 men, 639 underwent radical prostatectomy, 734 underwent external beam radiation therapy, and the smallest group was 436 that got external beam and brachytherapy. These are the mean ages, 61, 67. Obviously, the radical had the lowest age. And the follow-up, the median follow-up was 4 years, 5.1 years, and 6.3 years for those groups, respectively. By 10 years, 91 radical prostatectomy, 186 external beam, and 90 combined therapy patients had died. The adjusted 5-year prostate cancer-specific mortality rates were 12% for radical prostatectomy, was 13% for external beam, and significantly lower was combined therapy at 3%. And let me go to the next slide, which shows this in graphic form. So if you're looking at prostate cancer-specific survival, the blue line was the combination therapy arm, and the radical and the external beam patients did similar. The distant metastases-free rate was significantly lower in the combined modality treatment arm for these high-grade patients, and the overall survival was not yet statistically significant, but as you could see, favoring the combined treatment arm. And just because people will mention this, in the radical prostatectomy patients, as all radical prostatectomy series, percentages of these patients did get postoperative radiation, mostly in the salvage setting, but in the adjuvant setting. So when we talk about, well, if you're going to mop it all up with external beam, in most studies, when you look at high-grade cancers, there is a percentage of those patients, even though radical was the main treatment, that did get adjuvant radiation or did get salvage radiation, and they are included in the outcome. So the take-home message here, I believe it, I've always believed it, is that combined modality therapy, which does treat, and I think the key piece is, it delivers the highest dose of any form of radiation to the prostate, but it also treats microscopic metastatic disease around the peripheral, and most of these patients with Gleason 9 to 10 got hormone therapy. The other interesting thing of this finding was that even though the brachy external beam arm did better than the external beam only, they had a much shorter duration in overall hormone therapy. So the patients getting external beam alone typically got long-term hormone therapy, where many of our patients from Sinai got 9 months. And so despite having a shorter duration of hormone therapy, they still did statistically significantly better. So now I want to switch and just kind of go over the randomized trial, the ASCEND trial, which was done in Canada, and this was a randomized trial, an analysis of survival and endpoints. It's a patient with intermediate and high-risk prostate cancer, and they were randomized all to get 1 year of hormone therapy, all to get 45 gray of external beam radiation therapy to the pelvis, and then re-randomized to get either an iodine implant as a boost or finish a dose close to, I think it was, because they gave 200 gray per fraction. I think the external beam dose in that arm was 78 gray, and that was the randomized trial. And both the cancer outpoints and the toxicities have now been published. So if you look at this is the proportion of patients biochemically free from progression, all the patients, you see a significant improvement in the biochemical progression-free survival for patients that got combined external beam and an implant. B is the same difference, statistically significant for intermediate risk patients. C is high-risk patients, again, about a 20 to 30% improvement in biochemical control with the addition of seed implant to that, and currently no difference in overall survival. And then an accompanying paper coming out at a similar time is looking at the morbidity. So this is the kicker here, was based on this study. And if you see that there, just to kind of summarize all the data, the main difference was that there were higher GU toxicities in the brachytherapy and external beam arm, mostly grade 3 toxicity. You can see that here. If you kind of look at the grade 3 toxicity cumulative incidence here, you have 5% in the external beam arm, and in the brachy arm you have 18%. That was a statistically significant difference. And here again, you see statistically higher incidence of GU toxicity in the brachy arm. Based on this, editorials have been written that that external beam only should be the standard of care, but I have to note that this is highly related to the technique of brachytherapy. This was a Seattle-based pre-plan. Needles and seeds were placed beyond the prostatic apex, and the main culprit of the increased toxicity was strictures. Now, Neil and I, especially Neil, did a specific one looking at our stricture rate and our toxicity rate in combined therapy. And other than what I had showed you in the where you may get some more potency, we didn't see this type of thing. And with a technique that you really know where you're putting those seeds, again, we favor a real-time technique, or paying more attention to longitudinal imaging and not putting your seeds into the beyond the apex of the prostate. I think you will markedly reduce that. And throughout our 25-year history, we have not seen these stricture rates at all. So our GU toxicity does not relate in any way to the toxicity from this study. But unfortunately, this is a randomized trial, and the message was, don't do combined therapy because the toxicity is too high. So on that note, I'm going to end, and I think it's been a nice review of the long-term data as it has matured over the years. Thank you.